Progressive markers, I briefly alluded, I'm going into detail. I mean, there are very many over years. I mean, there have been massive publications. The point is that we don't need to do them all, but we need to do a few. And the main ones are really cytogenetics, which are FISH, and namely 17p deletion and 11q2. And that's extremely important, and I'll come back to that. The other is that we should also do sequencing for p53. The patient may not have a 17p deletion but could have a p53 mutation, so you should do both. That ties me back to the accessibility, because FISH is more widely utilized, but sequencing is, I mean, even in, as I was saying, in luckier countries, not always done on all patients. So that is an issue and should be done. The other key marker in terms of prognosis is the immunoglobulin status, because we've known for a long time, for some 20 years more or less, that if you have a mutated profile, you do better. If you have an unmutated, you do significantly worse. Now, over the years, we've understood the reason for this, which is largely related to the B-cell receptor, which plays a role in CLL. Now, this is very interesting, because now we have drugs that target the B-cell receptor. So what is happening is with the new drugs, ibrutinib, idelalisib, the prognosis response to treatment of the unmutated is more or less similar than the mutated, which in the old days we did not have. The question is that these tests should be done, and in fact the recent guidelines which have just come out in literature say that, I don't remember the wording, but it's not recommended, let's say mandatory, or it should be done, both the FISH, sequence of P3, and for immunoglobulins. When you do it, you don't need to do it at diagnosis. You need to do when you treat a patient. So that goes back to what I was saying earlier. I mean, not only in more than the richer countries, where even there not all patients are tested, but if you go outside of that, I mean, this is a major problem. So why are they important today? A, because as I mentioned, the unmutated patients, or the patient with p53 or 17p, respond better to the new drugs than they did with the conventional chemoimmunotherapy. That's very clear. In fact, if you look at the indication, the first indication in Europe was for 17p mutated, deleted, and p53 mutated was ibrutinib frontline and idelalisib plus rituximab, which was an extended indication by EMA, extended the filing of the companies, which was for relapse. So that was important because of the unmet need of these patients. So it's very important that you test them if you have the new drugs. So you see, the things have to be tied together. If you have new drugs, you test. If you don't have new drugs, that's paradoxically less important. But we should test and give the new drugs if they're mutation status, because we know that if you're unmutated, response to chemoimmune is not very good. So you should probably go to new drugs if you can give them. So recently, both last couple of years, FDA and EMA have approved ibrutinib frontline for all patients. So that gives a further opportunity if the drug is available. We go back to the old story. So then the challenge is going to be, if you have the drug, if some patients can be maybe spared the new drugs because of the cost issue. Drugs are expensive, let's be very open. These drugs are containing the disease, they're not eliminating. So in theory, the drugs are forever at an important cost. So that is the challenge. So we're trying to optimize. So what is happening is that if you do the immunoglobulin and you're mutated, even frontline, I think we would suggest that these patients could go to conventional treatment, chemoimmunotherapy of FCR, bendamustine, rituximab. So that is a way of, algorithm of optimizing resources. So that is prognostication. You mentioned MRD. So MRD is a step forward. MRD is not obviously at the beginning, it's after treatment. So this is changing the scenario again. As I often say when I give talks, is that the definition of response in CLL has changed dramatically. When I was young, in the old days, we gave drug which was called, and still is available, chlorambucil, and that's just what you did. Reduce the white blood cell count, and we're just monitoring the blood. Then the combination chemoimmunotherapy were more effective, so we learned that maybe some patients could respond very well. We started looking into the marrow, because the patient appeared to have a clearance of blood, so we went and looked into the marrow. And that's where MRD started to appear, because we saw that some patients seemed to be cleared of their disease, so we started monitoring by flow, which you can monitor well. And that then moved from the clearance of blood to the clearance of marrow, plus started to consider MRD. Then when the new drugs came, the ibrutinib and the lallisib, the scenario changed again, because these drugs have a limited debulking activity. They control the disease. So the disease is there, but it's kept under control. That's why it's continuous treatment. You don't stop. So we've gone back. And now we are going back the other way around. We're going forward and going back to the MRD story, because the combination of the new drugs, which are not approved, I mean, they are ongoing, but the data, the preliminary data, something we discussed here, presented at ASH next month, clearly show and will confirm that combining the new drugs up front, you can get a very, let's say, much more profound response. And many patients seem to be becoming MRD negative. That means that you're testing with much more sophisticated technologies, flow, and even molecular PCR, to see if you can maybe eliminate all the cells as much as you can do. So this is a paradigm which has changed. But as I said, the studies are ongoing. We haven't finished that yet. But that's going to be the future, probably. If we go back into reality and future, I mean, it'll take some time. It'll take maybe 2 or 3 or 4 years to have firm data. But we're going towards exactly that, the combination and possibly frontline of maybe allowing many patients to become MRD, immunocellular disease negative. So that's literally for the future, but ongoing future.